All right. So the meeting is now being recorded. We've also conducted various other events, such as an on-ground camp on field presentation, providing hands-on experience in clinical assessment techniques. Um, we are we cordially invite everyone to all undergraduate and postgraduate medical and allied health students to join our organization. It's absolutely free of cost. And it provides access to exceptional networking, learning, and professional development opportunities. We have shared the general membership link, and you can find it in our across our social media handles if you are so inclined. We'd like to talk a little bit more about this collaboration. It's a panel discussion on female genital cutting in India and the role of medical practitioners in the same. We have with us, it's a collaborative effort with Equality Now, which is a very renowned organization. Um, and Julie is a representative from there. It's in collaboration with We Speak Now, if I am getting that correct. Uh, We Speak Out. Right. I am so sorry. Apologies for this slip of tongue. And Masuma is here from there. And we have Dr. Diana and Dr. Hannah, who have agreed to take out their valuable time and enlighten us on the issue. With us, we also have Dr. Ajmera, who is a panelist from SIMSOG side. So without further ado, we'd like to uh, ask Julie to take over and provide insights on this issue.
Thank you so much, Shivani. And thank you to all of you for taking the time out. I must say a big congratulations to everyone. If you have just started on the 8th of March of 2024, I think you've taken big strides to be talking about FGMC towards the end of the year. So less than 9 months, and you have started talking about fairly difficult conversations, to be honest. And so we're only too happy to share our information and knowledge with you, and hoping that you will be fellow travelers in this journey, because we have been on our own, and I know Masuma will be talking more about this. She's the one who's kind of spearheaded the conversation in India. So we are only too happy to have more people join the conversation and do their bits for making sure that this practice is addressed, people are aware of it, and hopefully we're able to end it in India. So if you look at the data that UNICEF has put out sometime beginning of this year, we have about 230 million women and girls worldwide who have had the practice of FGMC done to them at some point of time. And you might be surprised to know that 80 million women and girls are in Asia. So I know it's a very common practice that when you talk about female genital mutilation or cutting, you automatically kind of link it to an Africa kind of a practice, and that it doesn't happen in the Asian context. And today, I'd just like to give a brief overview of the practice in the Asian context. We have about 13 countries in Asia where the practice is known to have to be done. And we have in South Asia, we have India, Sri Lanka, Maldives, Pakistan, where the practice is known. We have evidence from there. And in the Southeast Asia, you have the practice from Indonesia, Philippines, Thailand, Singapore, Brunei, and I think you also have in Malaysia. Dr. Hannah and Diana are from there. And I think all of us kind of are trying to share this information more widely, and to say that, look, this is an Asian practice too, and we need to accept it and to make sure that we are having the appropriate policies and practices to end it. Hoping that we'll be able to do it by 2030. It seems a bit unlikely, but at least it becomes a start. So I'm not going to give you more details. The only 2 countries in Asia where you have official data about the practice of FGMC is Indonesia. I think they have started somewhere in 2005-6, and they have a plan, relevant policies, and I think some orders, government orders, to talk about this issue. And the other South Asian country where you have official data is the Maldives. And if you look at the Maldives, they are saying it is part of their demographic household survey, and they have found that there are 13% of women of the age of 15 to 49 who have undergone the practice. And it seems that the percentage of women who go through FGMC from 15 to 19 is 1%, and it increases when you go up to the ages of 45 to 49 to almost 38%. So evidently there it's happening too in the Maldives. The practice is being undertaken on young women, whereas in a lot of the South Asian countries, it is happening to young girls, almost at the age of 7, even 40 days. And I think Dr. Hannah and Dr. Diana will be talking about that, the impact of that. In Sri Lanka, you have it, the practice is largely is known to happen in the Moor, Malay, and the Bora communities. In India too, it is the Bora Muslim community, but you also have evidence of the practice being undertaken amongst some Sunni Muslim communities in South India. And again, Pakistan, not much is known, but it might be that it is more widespread amongst the Bora Muslim community. And you do have women from the diaspora community based in, say, the UK, the US, Australia, and other countries where they are located. They are also subject to this practice. So sometimes their parents bring them back to their home countries, and if it is like India, and they are cut here, and it is known as vacation cutting. And the global data says that about 12%, every 12 minutes, a young girl or young woman died due to complications from FGMC worldwide. And there is really no specific law in the Asian context to deal with FGMC. But we are also seeing increasing medicalization of the process. So traditionally, the parents or whoever in the family would take the young girl to the traditional cutters who were not trained. But now, because you have a growing awareness of the problems that might be created because of being cut by traditional cutters, there is a move towards going to medical doctors. And I think, again, you will hear more about it, so I will not talk about that aspect. But just to say that the healthcare costs for the practice of FGMC is 1.4 billion annually, based on data from 27 countries only. And if we were to abandon FGMC, this could actually be reduced by over 60%. I think initiatives to talk about FGMC, it's the practice, the harms of it, has largely been started by survivor-led organizations like We Speak Out, or by individual activists in most of the South Asian countries. I think they have been at the forefront of engaging with community members, with the women in the community to say, hey, this practice happens. Are you aware of what the impact is? Then talking to the larger community, the younger members of the community, even to the religious leadership, the government ministries. And we've made some efforts of engaging with the medical bodies, not too much. And also using, let's say, the international treaty bodies and mechanisms to bring attention to the practice in the South Asian country, in the South Asian region. So, sorry. I think from the work that we've done so far, and I'm sure all the panelists would be able to talk more about it, the one main thing that we would like to do is to shift the narrative of this being an African practice to a practice that is happening right now in Asia and in India, to be honest. And the fact that there is no law to deal with it, the fact that there is no acceptance of the practice being widespread across the country. And the only way to go about doing it is having a multi-sectoral approach, where we see that the role of the medical practitioners in the coming days would be much, much more critical and crucial. And we're also saying that there could be ripple effects for change happening in any one country to be able to bring about changes in other countries. I'll stop there. Happy to take any questions and to share whatever resources we have. Back to you, Shivani.
Thank you so much, Julie, for this. And apologies for pinning you very, very late. We just discovered that phenomenon, but I think your words were pinned and etched into every single speaker's minds. It was indeed, and it was quite an eye-opener. We'd like to inform all the speakers that the bios of the speakers are being posted in the chat box as they speak. Thank you for the brief overview, and globally and in Asia, I think that was much needed to set the tone and to make sure that the participants are well aware of the gravitas of this social evil, if I may call it that. I think we'd like to move on to Masuma right now. So I am going to pin Masuma for everyone. And Julie, I'm going to unpin you if that is okay. Right. I do not know how to go about the unpinning bit, but this next segment is going to be taken care of by Masuma, and I think Sana will be posting the questions so that everyone can follow as well. Right. So Masuma, what have been the key moments of work around FGC in India, and have healthcare providers been an integral part of the same? And how can they contribute if they wish to? What are some of the positives and what are some of the challenges related to the medicalization of this practice, that is FGC? Right. So with that, Masuma, the spotlight is yours. Uh, Thank you for taking out the time again.
Masuma, if you can hear me, you're on mute.
Okay. Am I audible now? Okay, great. So thank you to SIMSOG for organizing this meeting and to talk about a subject which really not very many people want to talk about or want to hear about. So it's really, really important, and it's really welcome. Of course, it's important to us because we are waging a battle against it. And but it's important for the medical community, it's important for students, it's important for society, basically, at large, to know and understand this topic. I speak here as an activist and as a survivor, and I want to start with my story. So I grew up in Mumbai and was part of a very, very warm, loving family. When I was 7, my grandmother used to come normally, during the vacation time. She would come from a village and spend time with us in Mumbai. And around the age of 7, I think between 6 and 7, I must just be turning 7. One day, my grandmother told me that she would take me out, just to meet some of her friends. And I was very excited because, going out as a young child was fun, and my grandmother would buy me some candies and ice cream. And so my mother dressed me up in my best dress, and I was super excited. I held my grandmother's hand, and off we went. I used to live in this place called Nagpada in Mumbai. If any of you are from Mumbai and you know Nagpada, it's in central Mumbai. And from there, we went walking to Bhindi Bazaar. And a large part of my community stays in Bhindi Bazaar area. And we went into this decrepit, very falling apart building in this Bhindi Bazaar area. And we went to the first floor of the building, and she knocked at a door. And it was opened by a lady who was of a similar age, maybe a little younger than my grandmother. And she welcomed us in the house. We went in, we removed the shoes outside because we normally have this practice of sitting down in the house as for us. So we went inside and she took us into an inner room and she drew the curtain and we sat down on the carpet on the floor. Almost instantly, this woman came and she was sitting then next to us. And my grandmother told me to lie down. Now, I couldn't understand why is my grandmother asking me to lie down, because I'm not, I mean, we are here to, meet a friend and then maybe go and buy some candy. But my grandmother said it'll take very little time, just lie down. And she kind of nudged me to lie down. And I couldn't understand anything. I was like barely 6.5. And feeling really uncomfortable. This lady on the other side, she pulled my pant down and she pulled my panty. And I started panicking and I was sobbing. Now, there are these two old women, one on either side of me. My grandmother is pinning me down with her hands, and the other lady is holding my legs. And I was trapped and I was really sobbing bitterly. This lady took some instrument. I don't know what it was, whether it was a blade or a knife. I don't know. I was just sobbing away. And she cut a part of my genitals. What she cut, I do not know. All I know was excruciating pain. And she put some black powder in the genital area. She put my panty, she put my pant, and she says, okay. By then, I was in a state of shock. I didn't understand how we got home from there. It was just all just a blur. And I just went home and I was crying. And my mother held me and she told me it's going to be okay, don't worry. And she kind of calmed me down. The memory of that day was so horrific. I was told to hush. I was not told anything about what was going to happen. After it happened, I was not told what happened to me. And there was like this whole shroud of silence around it. It was just hush it. And there was a lot of pain while passing urine for the next 8 days. And the whole trauma of that moment, of that day, stayed with me. Now, I was too small and too scared to ask anybody anything at that age. And the memory of that day was kind of blocked inside of me. But I carried the seeds of that trauma well into my life, into my adulthood. And even today, I kind of shudder at the thought of what happened to me as a child. 45 years later, in 2012, there was a spate of articles in the newspapers on the subject of female genital mutilation. And there were references to our community and about the practice. In 2012, there was the first case of female genital mutilation in Australia. And it was a case about two young girls, aged 8 and 6. And it was members of my community, both these girls of my community. The family was from my community, which is the Bora community. And they were on trial. They were on trial for having cut these two young girls. And in the case, the prosecution, it was, of course, the state which was prosecuting. But on the other side, on the defense, was the mother of the children who had taken the kids. There was a nurse who was involved. The nurse had performed the cut, and there was a priest. So there were these 3 defendants, so to say, or respondents in this case. And because of this case, and because it was a case from the Bora community, there was a lot of media coverage which was happening in India at that time. But what was significant is that this was performed by a nurse. So it is a healthcare provider. In my case, and at that time, when I was growing up, it was basically being performed by a lady, an old lady, or it could be a young lady also, but a woman with no medical background. They were called the daimas. and it was something which passed from generation to generation. So she would probably teach her daughter to kind of do it, and there was a little bit of money involved. So it was an economic transaction also. And it was a tradition, it was a cultural tradition which got handed down from mother to daughter, and it's been going on. And I can tell you for a fact that when it happened to me, it was pretty much prevalent, literally 100%. Everybody in my community was being cut. Years later, when I started We Speak Out and I started speaking about what this whole practice is and how it is, we are like subject to this whole shroud of silence and we're not allowed to question this. We don't really know what happens to one of the most intimate parts of our bodies, why it's done. And when I started searching for answers, that hard facts came to light. One of the biggest reasons why female genital mutilation is practiced in India or any part of the world for that matter is it is directed to your sexual organs. The most important sexual organ for a female to experience sexual pleasure is the clitoris, and female genital mutilation is targeted towards the clitoris. It is the cutting of the clitoris. So what happens in our community is what is defined by the World Health Organization as type 1 female genital, type 1 cut, which is the cutting of the clitoral hood. Now, as doctors, all of you know the clitoral hood and the clitoris, the part which is visible outside, is very, very small. It's very, very tiny. And it is a bundle of tissues. There are 60,000 nerve endings which are there. And the cutting of the clitoral hood is what is done. And the conditions in which it was done in my case, and then later on with the nurse in this Australia case also, it impacts the sexual function, the sexual experiencing of sexual pleasure amongst young girls. This was in 2012, and this was a time that, we started meeting with survivors and we founded the organization We Speak Out with the objective that one is we want to understand what's happening. Two is we want to talk about it. We want to break this whole culture of silence. We want all of us to understand what's happening, but we want the world at large also to know what the practice is, and we want an end to the practice. So, another case which happened, which is again interesting from the point of view of medicalization, I'll talk about medicalization, is a few years later, I think about 4 or 5 years after the Australia case, there was a case in America, in Detroit. Again, a medical professional was under the scanner, a Dr. Nagarwala. She was being prosecuted and she was in jail also for having performed female genital mutilation on 2 young girls. And as the prosecution was investigating, they found evidence for almost 100 girls who were being subject to this. So this was happening by a doctor, and it was happening in a clinic in Detroit, and it would happen over the weekend when the clinic would be shut. Okay. It is illegal in America. It is illegal in Australia. So it is against the law in both these countries. FGM is, as a practice, is banned. And medical professionals, both in Australia and America, again, belonging to the same community, people from the Bora community who have roots in India are performing this practice. So let's talk about, so this is in a nutshell what the practice of female genital mutilation is, okay? And the attack primarily is on the clitoris. Now, there are 4 types of FGM, and it's important for you as medical professionals to know that type 3 is the most severe form of female genital mutilation, which involves the cutting of the entire external genitalia, which is the clitoral hood, the clitoris, the labia minora, labia majora, and the vaginal opening is sued. Okay, and just a small opening is left for passing urine. Okay, now this is the most horrific form of female genital mutilation. It happens in several countries, and at the time of marriage, what happens is the sexual act itself is extremely painful, and it is only at the time of childbirth are those stitches removed. So this practice is called infibulation. And what happens is after childbirth, there is another practice which is called re-infibulation. So that she's stitched up again after she's given birth to the child. So, I mean, look at the horror behind the whole nature of what is happening. So when we talk of medicalization, one is we are talking about that it is being performed by healthcare providers. So while earlier it was performed by, local women who kind of got it from their mothers or grandmothers, now it is being performed by healthcare providers. One of the biggest reasoning and biggest arguments given for medical and healthcare providers to be associated and getting involved with this practice is that it will become safe. FGM cannot be safe, whether it's done by a medical health professional or it's done by a daima. There is no thing of safe FGM. Okay, it violates the basic human right to be free from violence, of bodily and physical integrity of a person, and the right to be free from any kind of inhuman, depraved act. And just as anybody has a right to sexual pleasure, women also have a right to sexual pleasure, and nobody has got the right to curtail or curb that right. The ideology behind female genital mutilation is to curtail and curb women, and that itself is wrong. So the whole concept of medicalization is actually very, very dangerous, because it's trying to sugarcoat the practice, and it's trying to say that, okay, we'll do it in a better way. We will anesthetize it. We will do it in a cleaner environment. We will do it in a hospital clinic setup, so as to justify the practice. And especially today, there's a lot of discourse on, by medicalizing the practice, what we are doing is you're reducing the harm. There's harm reduction. But at the core of it, it's an extremely unethical practice. And it is something which has to be called for, and especially today to students of medical science and to doctors and obstetricians and gynecologists. I think this is extremely important to understand what female genital mutilation really is, what it does to a woman physically, emotionally. There is no focus on what happens emotionally. The trauma which I faced as a child, I carried it through my life. Okay. And the kind of research that we've done over the years, where we've talked to women who've been survivors of this practice, it definitely impacts their sexual pleasure. It impacts their marital life as well. So the amount of damage that you're doing, the kind of mental health issues which women do go through because of this are enormous. In fact, I'll give you one small instance of a case which we witnessed in India a few years ago. This was in Surat, where a young girl, again 6 or 7 years old, was cut by a traditional cutter. Now she was cut so badly that normally the bleeding stops in some time, quickly. But in this particular case, this kid was bleeding through the night. The mother had changed 2 bed sheets. By the morning, the mother was panicking. She called the cutter, and the cutter told her, just put soframycin. This sometimes happens. It will settle down. It was not settling down. The bleeding was not stopping. She took her kid to the hospital. Now, the hospital saw a child, a minor, bleeding from the genital area. The hospital panicked because they thought it's a case of rape, and they refused to admit this child. Finally, through some friends, she went to another clinic and to a doctor, and the doctor sued her up. But the kind of psychological trauma this kid went through and her mother went through, it's never going to leave them. So the point is, there is physical harm and there is emotional, mental, psychological damage which happens. And I think survivors and boras and women from the communities are raising our voices. We are doing that on a daily basis. But I think we need support from communities like the medical community, by gynecologists, obstetricians, students, and world at large, to call out this practice, the act of FGM for what it is, and to spread awareness about this. The doctor who treated that child also did not know what FGM is all about. I know of a young girl who was subject to it, and she was so worried. She went to a gynecologist and said, this has happened to me. What is the impact of it? Her gynecologist was not able to answer that question because the gynecologist did not know what the practice is and how will it impact this person. So yeah, I think I'm going to end my talk by saying that there is a moral and ethical responsibility with doctors especially, but with society also at large, to call out something like this and to um, help in breaking the silence around it, breaking the secrecy around it, and creating a groundswell of public opinion to, stop the practice. Thank you.
Thank you for that, Masuma. I think everyone's hearts shattered a little when we heard the stories that you've amassed over the years. We do want for medical practitioners to future aspiring OBGYNs as well, especially, to be more aware of this practice so that we can help out those in need. And I think what better a way to emphasize on the importance of us knowing about it than by inviting a panel of three very well established OBGYNs, Dr. Iman, Dr. Ajmera, and Dr. Nasri. I think Dr. Iman and Dr. Nasri would like to go together. That was my understanding. I'm going to pin the both of them I'm going to pin their tabs on the screen at the moment. And for Dr. Nasri and Dr. Rafiq, the question is, what is the medical perspective of FGC and why is it considered harmful for women and girls? Of course, Masuma has given an overview of the same. If we could go into a little more detail, because we're all aspiring clinicians and clinicians to be over here. So Dr. Nasri, Dr. Iman, I'm just gonna pin your tabs. Please let me know if that has happened.
Yes.
Okay, great. Dr. Ajmera, is there something you're seeing? I think Dr. Ajmera, we'd like to invite you to go next, if that's okay.
Hello. Hi, everyone. Thank you so much for inviting us to your event. I think it's great that we're talking about FGMC. It's a topic that's not rarely spoken about in the medical school curriculum. And of course, because all of you are medical students and aspiring doctors, aspiring OB/GYN doctors, I feel that it's a good idea for us to go through a bit more of anatomy. And without further ado, I would like to invite Dr. Rafiq, who is our family medicine specialist, to start, and then I will continue the presentation. Dr. Rafiq, over to you.
Hello, hi everybody. Thank you for having me, and thank you to everyone present for taking time to listen to what we have to say today. So Hannah and I came together a few years ago to form Malaysian Doctors for Women and Children, where we both studied in the UK and graduated from UK medical schools, and decided that there was a gap in the what we're being taught. And I suppose when as you graduate and you become a junior doctor here, it's compulsory to do safeguarding training. And as part of the safeguarding training, there is an element or a subtopic of FGM. And when I first heard about it, that Malaysia was one of the countries that was, I think it was 70%, correct me if I'm wrong, Hannah, 70 something or 80% of the female population are deemed to have undergone some form of FGM. I was quite embarrassed and sort of had my tail between my legs thinking, oh my gosh, and my friends were looking at me saying, aren't you from Malaysia? So yeah, and I thought, yeah, we definitely need to talk about this. So I'm Diana Rafiq. I'm a GP partner here in Flitwick. You probably won't know where that is, but to put things in perspective, it's in Bedfordshire in the east of England. I'm the adult and child safeguarding lead. I'm also the clinical governance lead, and I'm also a GP educator and trainer. So just going through briefly, I'm sure you have learned and you have a basic understanding of what FGM is. And as Masuma correctly said, in Australia and the US, it is illegal. It is also in the UK illegal and to carry out FGM, female genital mutilation or cutting. In the UK, general practitioners and all doctors. Also, I think since last year or a couple of years ago, they have included teachers as part of the team that have a duty for mandatory reporting. So we have a specific role in identifying and reporting female genital mutilation under the Female Genital Mutilation Act 2003, and this was amended by the Serious Crime Act in 2015. So it's more, I think the question is more looking at the medical aspect of things. And if you look at our lovely little slide here with this quite graphic diagram, as Masuma correctly said, type 1 is the clitoridectomy, where it's part removal of the clitoral hood, type 1 is divided into type 1A and 1B. Type A is removal of the clitoral prepuce or the hood without removing the clitoris itself, and 1B is removal of the clitoris partially or totally. So that is type 1. Type 2 is more excision, where you have it's then broken into several categories. You have 2A, B, and C, but essentially what it is, it's removal of both the clitoris and the labia minora, which is the inner folds of the vulva, which I'm sure you all know. And then it can also involve removal of inner and outer labia and clitoris. That's the type 2C, which is the worst form of type 2. And then type 3 is, I suppose, quite a gory type of the FGM categories, as Masuma mentioned about the infibulation. So type 3 is the most severe form. It involves the removal of the clitoris and the labia, either partially or entirely, and then stitching or sealing of the vaginal opening to narrow it. So then it just leaves essentially a small opening, not very large at all. So, and this opening is left for the passage of urine and menstrual blood, but most of the vagina remains mostly sealed. And yeah, correct. I'm just repeating what Masuma's saying is about the cutting or reopening, where when during marriage or childbirth, it gets cut open again, and then the procedure called re-infibulation is usually performed in certain demographics after childbirth and after marriage. And then we move on to type 4, which is any other practices and anything else that you do, any other harmful procedures. And that could include pricking, piercing, scraping of the clitoris or the labia. It could also include cauterization, burning of the clitoris or labia, and also insertion of corrosive substances or herbs into the vagina or vulva to tighten or narrow the area. And this is all, I suppose, paired with the myths and the cultural or religious or whatever beliefs that the vaginal opening or vulva should be narrowed. And then stretching of the labia can also be deemed a type 4 FGMC. Yeah, correctly so. Type 4 practices, I mean, correct in the definition, but wrong in the practice. It is often intended to cause harm and to control a woman's sexuality. So going on to the next slide, it's a bit of a gory image again, and I'm sure you've come across this in your anatomy books, in your anatomy topics in medical school, in your specialty training. But if you see the clitoris is actually quite a large organ. You've got quite a lot of blood vessels, you have vasculature and nerve endings and structures that move along the clitoral body. So even if you'd imagine just nicking a little bit off the hood or the prepuce that's above the clitoris, you could then be damaging veins, nerves, and if you go a bit deeper, just by a couple of millimeters, you could then damage arteries. And then we've got the next one, Hannah. Yeah, Hannah put this together, and it really is quite a good depiction, really, of how tiny. So a little baby, a little newborn baby girl will have, these are based on these studies, have shown and measured the size of a female newborn glans, clitoral glans, of how tiny it is. So 0.6 millimeters, that's hardly anything. So up to the age 0 to 3, it's the mean goes up a little bit, 0.87, so it's still under 1 centimeter. And as the child grows, the clitoral hood or the prepuce does have the ability to grow and become more retractile. So if you think about a female newborn baby, the hood is actually quite close to the clitoral glands. And so just snipping or saying you're just going to snip the hood could cause a lot of damage and lead to stunting of the growth then of the hood growing along with the child, because it's been cut off at such an early age. Next slide, Hannah. Yeah, this is just a sort of an analogy to put things into perspective. You know, you feel a lot with your hands, your fingertips. You've got thousands of nerves that are innervated by different nerve branches, your ulnar nerve, your median nerve, your radial nerve, and that's just 16,000. And if you think about a tiny clitoral glans, it has in that tiny area such a large surface area, so almost 10,500 nerve fiber endings. So it just puts things into perspective, really, that it does do a lot of damage. Although some people who say, well, type 4 is just a little nick, or it's just a little prick. What are you pricking? What are you nicking or burning? And how much damage are you going to do? And how many nerve endings are going to get destroyed and never heal again? Next slide, Hannah. Oh, yeah. We missed that bit. That it's got a lot of potential for growth, your whole length of your clitoral shaft, because the clitoris is not just the thing you see at the tip, but it's a whole system, a whole unit that has a lot of growth that needs to happen.
Yeah, so just to simply put into perspective, if you remember like a newborn female infant, the whole clitoral shaft, I mean, it can be a bit confusing because we've written there clitoral glans and clitoral prepuce, but because it's highly adherent to the clitoral body, i.e. the clitoral shaft, so they measured that, it's less than 1 millimeter. It can grow up to 37 millimeters. So there is a growth potential 400 times. And remember, like the nerves are just 6 millimeters underneath the clitoral glands.
And I think a lot of the myths surrounding FGMC is that it's to control a woman's sexual desire or sexual motivation. But if you break it down really, and you think there are different things, different components that lead to sexual desire, and this could be your drive. So what in your brain, what neurochemical responses and neuroendocrine things, and the clocks are ticking, things are moving to make you sort of engage in and develop a drive or a sexual desire, and then your motivation has to be present as well. So it's not just wanting to have a sexual desire, but it's also having motivation. So if you're in a relationship, you have a partner, a husband, a wife, whoever you have to be motivated enough. And then the other thing is obviously wish, and that falls into consent and consent and what your cultural values are, what is deemed right for you at the time, you and your partner, based on your beliefs. So all those three things or subcategories then lead to your sexual desire. But then you also need to have an ability to become sexually aroused. And so you need your physiological response. You need your genitals to be working correctly, and sort of everything needs to be the nerve endings should be intact. They should be able to do what they need to do based on the stimuli that you're giving your genitals. So it's just making a distinction that sexual stimuli is different to sexual motivation. And in cases where, sadly, when there are women or men who are sexually abused or assaulted against their will, and it's non-consensual, it can often be misconceived or misconstrued as well, that they were wet, or they were, they did feel hard, or they did this, but it wasn't, although it was non-consensual, there was no motivation and no consent, but your body, your genitals are going to respond, because it's a physical, a biophysical action. So it's just about being careful about using those terminologies and being aware that there should be consent as well. But next,
if I may as well, I would like to add, sexual arousal, sexual desire is quite complex. They can also influence each other, which is why that it's not quite true to say that everyone who has experienced FGM do not have a sexual drive, or they don't have a sexual desire. They may have a strong desire to experience sexual experiences, but may not have the same enjoyment as women who have not undergone FGM.
And then we talk about, I think this is just a sort of going through the complications, as you can imagine. Type 1, you've got, obviously, as our previous speaker said, about the bleeding, the risk of hemorrhage, intense pain, swelling, and wound infections. Tetanus is is a possibility, because in some countries they use gadgets and devices, instruments that are not hygienic. And then you get long-term complications about the nerve endings being trapped. You can have neuromas, growth of your nerves that kind of you're trying to protect yourself, and therefore you get neuromas build in response to trauma, keloid scarring, and then I think this sexual dysfunction we've talked about, and cysts, which could evolve later and become infected. And as a GP, really, in primary care, when we see or suspect that there are any complications in an adult woman who has in the past underwent FGMC, then our role really is to refer her on to the specialist FGM clinics, and usually they're run by obs and gynae specialists, and they help deal with these issues. And then I think the next one is type 2 and 3, which is similar. So all the type 1 stuff, all the risks and the complications are the same. And then you have the other issues with the type 3 women who are left with a small orifice that can be incredibly painful and uncomfortable. And of course, obstetric complications, prolonged labor, fetal death, maternal death. And then I think I'll leave type 4 to you, Hannah, if that's okay too.
That's fine. So there is a huge misnomer thinking that type 4 is harmless, minimal, it doesn't cause any pain. Actually, of course, the physical impact depends on the type as well. So I can tell you all the different type 4s in the world, and we'll go through them. So piercing is, well, historically used as a chastity rings over the labia in the Roman times, but now it's for self-expression and sexual enhancement. So in the UK, this is recorded as type 4. So if you have women when they book their pregnancy, and the midwife will usually ask them lots of questions about their past medical history, past surgical history, and also if they've undergone female circumcision, or if they have any piercing, we record that as type 4. But it's not, you don't prosecute it under the FGM Act if it's consensual. Obviously, like anyone below the age of 18, there may be a bit more questions, because it's not legal for anyone under the age of 18 to undergo any genital piercing. You can read the complications, so I wouldn't go through them. Another type is incision, and this is practiced in South Africa. This involves small genital, abdominal, or breast incisions to introduce herbal love medicines. They're typically performed by traditional healers or trusted friends to strengthen relationships and enhance sexual pleasure. Of course, it can cause scarring, UTIs, itchiness, burning, and irritations. The South Sotho people as well, they have a different form of incision. They break the hymen with a finger animal horn. And the Lubudu peoples make a small incision above the clitoris as well. And this is seen as a female rite of passage. Gishiri is another practice by the Hausa and Fulani people in the northern Nigeria, which involves cutting the vaginal wall with a razor. And this is presumably to address any gynecological issues like infertility, itching, menstrual problem, labor difficulties. Obviously, like I'm not sure how this helps. And this can cause various problems like vaginal swelling, fistulas, and uterine damage. Another type is the incision or scraping, and this is believed to remove a seed, which presumably cause sexual or physical issues. Again, practiced by the Hausa and Northern Nigeria people. And pricking is seen commonly in Southeast Asia, and in Indonesia, Malaysia, and the Philippines, presumably with limited physical harms, but potential psychological impact is not being investigated thoroughly as well. So there was an image of the clitoris just now, and I think I did circle a red area around the clitoris, and we know like how the nerve endings, the arteries are just millimeters underneath the skin. So if you prick, you can potentially like damage them and cause a lot of bleeding. And many doctors do not actually screen your patients for any infectious disease or for any like bleeding problems. And in Malaysia especially, it's done under the age of like 6 months old. Although that anecdotally, I have met a couple of people who had it done when they're 5 to 6 years old. So they remember the procedure to be done. And obviously it's really, really painful, and it can cause trauma into adulthood. So the psychological impact can cause shame and stigma, and women who have experienced sexual dysfunction, they may avoid intimate relationship, or they may feel ashamed of their bodies, potentially leading to sexual phobia. And of course, they can cause serious repercussions for childbearing and marital happiness. And now you must remember that in Southeast Asia, in Malaysia especially, like it's being done to babies, newborns, so they don't really remember the practice, but obviously they may grow up having chronic pelvic pain. And as we know, like historically, like we don't really diagnose people with chronic pelvic pain properly. Like there's problems diagnosis endometriosis and a menstrual disorder. So they may wrongly or rightly attributing the chronic pelvic pain due to the FGM. And there are some women who think that not being circumcised causes their marriage failure. And especially in societies where there's lots of myths going on that, not being circumcised means that you don't enjoy sexually. Obviously, that's wrong. And we've explained that through the anatomy. So FGMC in Asia, this is just a huge, some of the countries where it's performed. And you can read more about it in this toolkit that I've written. And in India, especially it's type 1 and type 4 with none to minimal bleeding. In the Bora community with a number of medical practitioners involved as well. And apparently there's an ongoing debate on the criminalization of the practice. And there's this assumption that medicalization is actually better because due to harm reduction. This is not true, especially in the Malaysian practice, because more doctors are doing type 1. So previously in Malaysia, it's done by traditional midwives, and traditional midwives tend to do a bit of pricking. Doctors tend to perform type 1, and they use surgical scissors or blade to perform this cutting. And obviously, you're inflicting a lot of pain. So there's a paper by Gox and Natal has shown that when they do fMRI studies on newborns and adults, they found that newborns actually experience the same amount of pain because the same area of the brain lights up. So why are we inflicting newborns to a lot of pain? They can't tell you that they're in pain. It's unethical. They can't give you any consent. And obviously you're removing too much growing tissue because, as we know, the clitoral hood is highly adherent to the body of the younger infants. So you could cause potential damage. So newborns may not remember what's happened to them, but it could cause potential damage. They may grow up into women who experience sexual dysfunction, chronic pelvic pain, and because they don't remember it, it may be hard to diagnose. So when it's done in older children, obviously, like, they remember the practice to be extremely painful, and some of them lose the ability to speak, hear, or see. It means that they are experiencing a lot of pain. So in summary, obviously, like, the physical harms of FGMC increases with the invasiveness of the procedure. Type 4 is not harmless. I've explained to you the different types. Any small prick cutting could cause harm due to the proximity of the blood vessels and nerves. So we've written about type 1 and type 4, we also spoke about the anatomy in this leaflet. You might be interested to scan it and have a look. And this toolkit was actually written for civil society organizations to engage with medical practitioners, but it has a good overview of the different practices in Asia, some of the myths, and you've probably heard as well, a most common one is like, oh, stopping FGM is just a way, it's just a Western agenda trying to limit the practices of a certain culture. Obviously, like, this is not true. We do know that in the 1800s, FGM type 1 was practiced by Victorians during that time to cure hysteria. And in the 1950s, you do see FGM being performed in white communities in America, in religious cults, really. But it does happen to everyone. It's not just in non-white communities. And secondly, like, you might be interested to read about the comparison between a female genital cosmetic surgery and also male circumcision. So I'm just going to stop there. Thank you so much. And I'll hand over to the team. Thank you.
Thank you to both the doctors for being this insightful, I think, because we're all, very interested regarding this topic as medical students. We've not even had the anatomy of the clitoris discussed or the sexual cycle discussed in such detail in our medical education systems. So this was indeed very eye-opening. I think we would like to give it without wasting much time to Dr. Ajmera. And Dr. Ajmera, are you there with us? Yes, thank you so much. Right. So we'd like to hand it over to Dr. Ajmera without wasting much time. Please note, everyone, that you will be able to access the material shortly. We are compiling it and sending it across later. And also all questions will be taken as after Dr. Ajmera has said her bit, following which we'll be having a vote of thanks. So Dr. Ajmera, are there any other medical aspects to FGM or FGC that our audience should be aware of and the implications of practice? And this is, I think, the most important and the question of the hour. What can we as healthcare providers or healthcare providers to do to ameliorate, to improve a survivor's condition, their quality of life? How can we engage in reparative measures? And I think Dr. Ajmera, I think you'll see her bio shortly and you'll understand why she is the best person to speak about this. So over to you, Doctor. I'm just going to pin you on the screen.
Thank you. Thank you so much for having me on board, SIMSOG. I think you have taken, as I heard from you, just some outstanding topics through the time you've begun in March, and really happy that you're talking about female genital mutilation in India. So very happy that the young gynecologists are as woke and as aware as we would really like them to be. Masuma, I heard you, and you've been so brave to talk up and talk, something that has happened to you because of a community. I think it requires immense strength and courage. So thank you for being here. The two doctors, you all have covered FCG so beautifully and explicitly made it clear. I think, what the doc here said is very true, that somehow, even though we are all OBGYNs here, we are students, and me who's practicing OBGYN now since 25 years, we are never discussing sexual health, unfortunately. And a lot of times, sexual health doesn't come as a part of our curriculum as gynecologists. I am actually practicing functional and aesthetic gynecology, and we've been talking a lot about female genital mutilation, functional and aesthetic gynecology, whether there have been so many implications back and forth about it. But one thing we've realized with time is whenever we start talking, or when I start talking to gynecologists, we always say that unfortunately in our setup, once we put in a speculum and we examine the patient's vagina, unfortunately, all gynac practice begins from the cervix, uterus, ovaries and tubes, and none of us really are looking at the external female genitalia, which is really, really important. I think my being here, I'd like to report that I have not treated that many patients who've had female genital mutilation, maybe 3 and 4 over the last few years. The reason they're coming to us is because we are practicing aesthetic and functional gynecology. And when we do that, a lot of our practice involves locally, treatments which enhance a patient's or a woman's sexuality. A lot of, clitoris is what we are looking at, a lot of talks around it, a lot of procedures around the clitoris in terms of how to make it sexually a more pleasurable organ for women. Of course, a lot of patients we treat now are also in the menopausal or perimenopausal age. We know that the clitoris, though it's so sensitive, we know about the 8 to 10,000 nerve endings. The clitoris also decreases the sensitivity with time. So a lot of our experience has gone into working with women who have decreased clitoral sensitivity, and we are hoping to amalgamate these into helping women with female cosmetic genital surgery. With genital mutilation, sorry. To enhance the overall experience of women sexually is what we are really working towards. To talk about the women who came with female genital mutilation to us, of course, one of them was vaginismus. I think vaginismus is not mentioned. Probably a lot of patients of vaginismus who come to us don't talk about female genital mutilation, but one of them had it. I think it required a lot of counseling. It required a multifactorial team which had the psychiatrist involved and us. And we could manage to inject botulinum toxin for her to help her with her sexual activity. So someone who was not allowing penetration of the vagina with even a tiny finger, we could help her quite a bit, though she was only type 1 of the female genital mutilation we spoke about. The other patient had chronic pelvic pain. We did a lot of mapping of pain till we realized it was a general reaction. There's a lot of fear and other components involved. But again, local treatment of regenerative medicine is helping a lot of these women. The third, a person who had very decreased clitoral sensitivity and has never experienced clitoral orgasms, who wanted to experience clitoral orgasms, we had put in PRP in the clitoris. And that is, of course, injecting the clitoris with PRP, and that helped her a lot. So while we are in the very nascent stage of using regenerative medicine and using energy-based devices for patients to improve their sensitivity, I'm sure if we work together in the longer run, a lot of newer methods could be brought about to women who have suffered from female genital mutilation. Of course, that's the treatment part of it. But coming to the other part, medicalization of it, getting awareness amongst our practitioners. about what it is, how it looks, how do we deal with patients, how to talk to them. We have a real long way to go. And I think we are in the process of discussing this and having some kind of guidelines put forward. But I'm speaking too early, but hopefully in some years to come, maybe we will have this and include this as a part of the general gynac training in India.
That was amazing. Doctor, do you have any other further insights that you'd like to add? Is there something else that you're looking to say and there was a technical glitch or something from our end?
No, I think.
Okay,
Yeah.
that's amazing. So thank you, Dr. Ajmera, for highlighting the reparative measures that we could take. And I think that has given a lot of students over here a little bit of a kick to research into what is functional and aesthetic gynecology, possibly as a career option. We look forward to maybe hosting a career advisory seminar of sorts later this year. With that,
I
I think
just one thing, sorry, which I did miss out. When it comes to quality of life is what we were talking about for women. Again, we've not had too much, working with female genital mutilation, women. But we are working a lot on cancer survivors. Now, if you look at the spate of cancer survivors, whether it is cervical cancer, there's radiation to the vagina, a lot of them coming with vaginal fibrosis. A lot of cancer survivors who are endometrial, ovarian, or even breast cancer survivors who have a lot of, sexual dysfunction, whether it is lack of desire, arousal, or perimenopausal changes in GSM. That's genital urinary syndrome of menopause. So, we just presented a paper with Tata Hospital. It's a very renowned, cancer institute in India, where we are talking about rectal cancer survivors because the vagina undergoes stenosis and fibrosis. We have been using energy-based devices, which are lasers and radio frequencies. We have been telling the oncologists to send us the patients early. We can talk to them about quality of life. And what we are helping them do is we are helping them achieve better urinary control, better rectal control, and a better sexual life, because desire, arousal, lubrication, pain, all of these factors can be controlled by simple treatments with lasers or radio frequencies. So we are really hoping to extend this quality of life to a lot of different fields of women who suffer from sexual dysfunction for various reasons.
I think that was indeed very insightful, Dr. Ajmera. Thank you so much for that. We hope to see more survivors of FGC if they are so willing to come up and seek treatment. And we hope to see this become a more talked about issue. I hope that our webinar was a tiny drop in the ocean that is the advocacy movement to end FGC. With that, I think we can open the panel. We can open the question and answer session for the panelists. If there are any questions, please go ahead, put them in the chat box. I think we've received a few. If those questions have been answered through the talk, I think that's great. I think I saw a few raised hands at the beginning. If there are people who wish to speak up, please raise your hands and we shall take the questions turn by turn. But I think our panelists were so insightful that all sorts of questions that may have arisen were already taken care of. It's okay. Dr. Iman has a question. Please go ahead.
Oh, hello. I saw a question earlier on, about half an hour ago. Somebody, CP Singh, has asked, what is the logic or reason behind doing this? And we may have touched on a bit along the way, and I wondered if you'd want me to just say a couple of things as to why this practice, what the reasons are, or the reasonings behind different cultures.
Absolutely, the floor is yours.
Well, I think one of them, as I mentioned in the past, when I was speaking, was that it is deemed, or one of the myths is that it is a religious requirement in Muslim religion But honestly, while some believe it is a religious obligation, Islamic scholars have clarified that FGM is not mandated by the Quran or any hadith. So it's not mandatory, although the belief is that it's mandatory. And also there's this reasoning that FGM ensures cleanliness and hygiene, but it doesn't. So evidence has shown over the years that it doesn't improve hygiene. In fact, it leads to other complications such as infections, which is not hygienic. Also, the people who use the practitioners or non-practitioners, I should say, who use instruments that are not sanitary. And then another reason that people think of doing this is that it enhances sexual pleasure for men. So the infibulation and leaving a very small passage or opening is deemed, or the idea is that it increases sexual pleasure for men. But I suppose it often causes pain and reduces sexual pleasure for women, and therefore impacting the overall sexual experience. And that FGM is also deemed a necessary rite of passage, that many communities view FGM as a traditional rite, but really it isn't necessary for any cultural identity or acceptance to go through FGM, although the mindset is that, or it's been deeply embedded over the generations. Or the other in Malaysia is that the thinking that, well, if you're a girl and you're born in Malaysia, then yeah, every girl should just have it. Every girl should have FGM, but it's not. I guess the misnomer or misconception is that it is not universally practiced in Malaysia, because the awareness is growing about its potential harms and human rights violations with FGM. And the other thing is that it prevents promiscuity. So this seed or whatever you're cutting off is that it's supposed to nip things in the bud, essentially. That FGM, there is no evidence that FGM influence sexual behavior. If anything, education and respect for women's rights are more effective in promoting healthy relationships. So that's all I have really with why it happens.
If I may add as well, I would like to tell you an experience. I'll put my hand down, sorry. I would like to tell you like my experience seeing a lady who we had to repeatedly de-infibulate her, because once she delivered, obviously like re-infibulation is illegal in the UK, but she would go back to wherever she came from and re-infibulate herself. And we tried to educate her, like, why have you done this? So my husband would leave me if I don't re-infibulate myself. And plus that I feel that I might, like just pass the urine as and when, and I can't really control it. So there's a lot of like education that needs to be done. Obviously, like re-infibulation is not a cure for incontinence, or like if you have any sexual problems, that's not the cure for it, but it does happen. And like, and at some point that you can educate these patients, but I feel there's still a long way in terms of like getting support from male allies as well. Like, we need to get male doctors, we need to get male allies involved in stopping this practice and not just focusing on the women. And then just going back to the other reason why I feel why doctors in Malaysia in particular are doing more invasive procedures as compared to traditional midwives. I mean, the myth is that FGC enhances sex. No, it's the other way around actually. Like, they perform female circumcision or FGC to prevent girls from being wild. So I think like logically in some doctors' brains are like, oh, to prevent people from being wild, we need to cut a bit more so they don't enjoy as much. I think that's the reason why. So actually, when doctors are performing it, it doesn't cause any harm reduction. It causes more harm, at least in the Malaysian practice.
I think it's what Dr. Nasri said makes a lot of sense, and we as doctors need to recognize that we need to cast aside our biases because our word holds a lot of power in society by virtue of our profession. Our word is respected, and like Dr. Nasri said, that if a doctor does it, it's considered to be more legitimate of a reason, and that's why medicalization does more harm than good. I think we've had a flood of questions, and I'm so happy to see that. Shiv Kumar, starting from Shiv Kumar Halkai, an idea or in which part of India it's mostly practiced, and any panelist is welcome to take that on, honestly. Julie included, just sort of putting it out there.
Suma, do you want to come in?
Yeah, I can come in. So it's in India, it's at the moment, it's largely, at least the evidence of FGM that we have is largely from the western part of India, where the Bora community is populated. So you have Maharashtra, Gujarat, Rajasthan, Madhya Pradesh. These are the four states in which you have a significant population of Boras. There's a smattering of them in different parts, but mostly in these four states. We have new evidence of FGM from South, specifically from Kerala. In some Sunni communities, it is there. We've heard about the practice amongst some nuns in South India. I've heard of practice in some tribal communities as well. As I said, that it's such a secretive practice that getting evidence of it is really, really difficult. So at the moment, we are just discovering newer communities, newer places. In fact, even worldwide, if you see, there are 92 countries in which we have evidence of this practice. And most recently, to join in the 92, so it'll be 93, is Colombia. That the practice is now evident there also. So it could be happening without information, without evidence, without, the world and society at large knowing about it. This is at the moment, there is no national estimate, there is no national survey. And we have done a research study. In 2018, we did a study, which is a qualitative research with 93 respondents from these four states. So, across age groups, across genders, and even cutters and doctors have been interviewed for that study. And we found a prevalence of 80% within the Bora community. Equality Now has done a study recently of Kerala, and we have some anecdotal evidence now of it happening there. But getting information is really, really difficult. And we've been trying to get the government to kind of, have some kind of a national survey to get prevalence estimates in India. But at the moment, we don't have that with us. I just add one more thing, which about this whole issue, which is being talked about, about how medicalization one is, it's got this whole it creates this faux impression that it's going to be less harmful, and as a result of which, what is happening is a lot of young women today who have gone through the practice with medical practitioners do not have a traumatic experience. So they have no problem with it. So it's also, and ideologically, it's being used as a tool to kind of justify the practice. And I know I've spoken to a lot of, women from my generation, all of them have traumatic experiences, and all of them are, carry those scars with them. A lot of girls who've gone through the practice with midwives also have scars with them. But when it's done with anesthesia, you're removing the pain part of it. So you're obliterating that. And then with the justification that this is for your good, this is for your culture, this is for your tradition, this is for your religion, it kind of, justifies it in the minds of people. And I think that's an extremely dangerous thing which is happening.
Thank you so much. And I think this is in perfect looping with the next question, which is how can we propagate the information that this happens, and, so that we can initiate this path to emotional and psychological recovery early, such that more people can speak out, pun intended. So any of the panelists, if they'd like to take this up.
Uh, so propagating, I think one of the ways in which this propagation can happen, especially from the medical community, from the gynecology, OBGYN community, could be, issuing statements, talking to the media about it, and, openly and clearly articulating your views against it. That can play an extremely important role in spreading a message that this is a not acceptable thing, and something like this has to stop. I mean, you remember this whole practice of female feticide. I think the medical community did play a very big role in terms of calling out to people within the community who were doing that sex determination. So within the community, if there is this messaging, and you can, as an association, you have an association, pass a resolution against it, share it with the media, and say that you are opposed to something like this, which is harmful, which is against bodily integrity, which is against a basic premise of a gender equal space, and it's a discriminatory practice.
Can I just add to that? As a person, practicing OBGYN in, Mumbai in India since 25 years, you're absolutely right. I think we did a lot for female feticide, and it's time we really start talking about female genital mutilation. We have been talking about it since the last 10 years, maybe it's gone in parallel with aesthetic and functional gynecology, which we practice. So all our talks, talk about a little bit about female genital mutilation. When we talk about spreading the, word, we do it at 3 levels. Primarily, one is directly talking to women. So a lot of us are invited for talks, with these large women kitty groups, or in offices and corporate talks we do on Women's Day and things like that, where we talk about healthcare. And we should also be talking about intimate wellness, which we have started doing, but we need to do it on a much larger basis. The second is to talk to the family physician level. So this is at the Indian Medical Association, where we talk to the family physicians about the various things happening. And the third is, of course, gynecologists itself, because awareness even amongst gynecologists is very poor. So yes, I think this is a good point. It's a take-home message for me. We shall try and do this. We have the All India Gynae Conference coming up in January in Mumbai, and we'll definitely talk about female genital mutilation at that point in time, and we hope to scale that so more and more people, we can spread awareness.
I know we're running out of time, but can I also add to that?
Please go ahead.
I think we've sown the seeds of all of the participants here to be champions for that propagation in some way or the other. And I think what Dr. Ajmera was saying, that, at the level of the IMA or FOXY, I think you'll have a lot of these conversations regionally, nationally, and even internationally. We've been trying to get in touch with FIGO and with FOXY to try and, while it is a statement that they have put out at the global level, but it has to come down at a national level for it to start making sense to people who are here. First of all, we need to increase awareness about it. So I think if there are a group of you who might want to initiate certain conversations, I think Dr. Hannah and Dr. Diana have already provided the tools, the papers that you can use to kind of share the information around. I think that's the only way that we can create more awareness around it. And if anybody is ready to work with us, to engage with FOXY, FIGO, IMA, to get these guidelines out, because I think it is there, but it's not articulated in as much as this is FGMC and this has to be stopped, and this is the role of medical practitioners. And I know we are running a little late, so I just want to address Apurva's question of, is there any legal recourse or laws for the same? As of now, as I said, there is no law, but we speak out in Masuma. We've been thinking about how we can draft a bill and how that might align with the rest of the laws, because you do have under POCSO, you're not supposed to do grievous harm. There is a section around that which can be used, but obviously I mean, if you have a separate law, it does often act as a deterrent. There might be another school of thought that might say that having laws is not enough because it's the implementation that becomes the biggest challenge. So we'll have to work that out, but happy to if there are others, some of you who are interested in engaging with the law aspect, maybe you can get in touch with SIMSOG or with us and try and get that, we can engage and see how we can improve on some draft formulations that we have. Thanks.
That's amazing. That's honestly an opportunity that
Just add this, even if your associations pass resolutions condemning the practice and supporting us, it can be an important tool for us. Like we have a case going on in the Supreme Court of India. There's a petition to challenge this practice. Now, if we have support from the medical community and, if there is a detailed explanation of how this harms the child and the woman, it's all an added tool in our armor, in this battle against the practice.
That's really lovely. I think we can take one last question, which is quite important. If a young girl comes to us with a cut and bleed, and I think Masuma had talked about a similar story, how should we ideally, as practicing physicians, even at, say, an intern level, or if they come into a casualty bleeding, how do we go about it? Julie, is there something you'd like to add at the moment?
Dr. Ajmera, would you like to go ahead?
Yes.
Yes, I think this is something we see quite often in our emergencies. I have studied in Mumbai in Sion Hospital, and often you will have a young girl coming bleeding. I think detailed history taking, of course, is extremely important. The commonest things we could find is, of course, people making up and telling us that she fell down and she hurt her perineum with the edge of a table or something like that, and there was a knife kept on the table. So I think, again, awareness of female, genital mutilation is important to understand that it can exist, because the eye cannot see what the mind does not know. But again, the moment you look at something like this, I think we've seen enough patients who've had cuts because of injury, and this will look completely different because it is very distinctly on the clitoris and we'll be able to recognize it. But as bleeding anywhere in the perineum, the principles of treating would be the same, that, apply ice initially, stop the bleeding. There are times when you might have to take a stitch to stop the bleeding. Of course, this has to be done under general anesthesia, involve the seniors, have a pattern, rule out any sexual assault. So these basic principles which we have learned about any genital bleeding will hold true in this. But when you're aware that such practices exist, because patients come up with stories, they'll never tell you we were attempting a genital mutilation. That is the important part of it.
Thank you, Dr. Ajmera. I wouldn't have been able to give that kind of advice. I would have come from it from a slightly different perspective. So I'm saying that maybe as a way ahead, I know that Dr. Diana and Dr. Nazri, they already have a curriculum that is kind of taught in the schools in UK. So is that something that we could adapt, develop on our own for the Indian context, and see if that's something that we could offer to the medical association? And we are happy to kind of facilitate that process. And but we do need your active participation to take that forward.
So we'd be very happy to do it, actually, because we already are selecting a topic. I go all across the country. In fact, tomorrow I'm in Pune. Last 3 days back I was in Nagpur. Then I'm in Baroda. We talk a lot about female cosmetic genital interventions in terms of functional and aesthetic gynecology. And I think I'd be more than happy to look into the program, incorporate it, and start talking about it. And then we can even take it to Foxy very easily.
I'll just add this. I know I'm out of turn, but I think this is going to be so important because, Dr. Sejal, one of the biggest problems which we are facing, and our opponents, those who justify the procedure of female genital mutilation, often tell us that, look, there is aesthetic and cosmetic practice what happens for the genital area. And, so that's people are going on their own and getting it done. So why are you objecting to this? This is religion and culture and tradition and all. So that becomes a big, big problem for us. But if, practicing aesthetists can say that this is wrong, it would be great.
Yes, absolutely. We go all out, at least as a president of the Indian Academy of Vaginal Aesthetics, we go all out and pass a statement. That's for sure. But this, because, we do functional and aesthetic gynae, this question is asked to me so many times that how are you not doing female genital mutilation? And we've had like hours and hours of explanation how the two are completely different and how we don't support female genital mutilation at all.
I just want to add that in this space, let me just lower my hand. Like in this space, especially when you talk about education and curriculum, it is true that in the UK we do have a curriculum, but I do feel that we focus a lot on Africa. We think that's only happening in Africa. So we do get women who come from one FGM clinic to another with the doctor saying, actually, like, there's nothing wrong with your anatomy, because if they've had it done as a baby, it's really hard to detect it as an adult, but they may have sexual dysfunction. So they keep going from one FGM clinic to the other, and they feel like the doctors who are seeing them are gaslighting them because, oh, you don't have FGM, you've not had it done. So they are invalidating their experiences. And because of this lack of awareness, and I do feel that sometimes the way we approach FGM in the UK is not perfect. For example, obviously, if you have a white female who's 25 years old who goes to her GP and say, I don't like the look of my vulva, I would like to have labiaplasty, versus like a black woman who, from, I don't know, Nigeria, who comes to her GP, I would like my clitoris to be prick. Obviously, like the GP, I mean, most GPs, not Dr. Rafik, of course, would assume that the black female Nigerian lady is asking for FGM and not someone who's asking for labiaplasty. So there is a bit of biasness in how we approach this. And I do feel like certain modules in the UK where FGM is spoken about is sometimes I feel it's a bit biased, and sometimes I feel it's not adequately moderated. So you have facilities who talk about this, and they don't actually moderate people who say like, oh, you are from a barbaric culture, we don't do this in our culture, it's a migrant practice, it's not our practice, yada yada, and so on and so forth. But as I've pointed out earlier, like we did practice FGM in the UK as British Victorians to cure hysteria, and this is something that you probably have not heard spoken about if you ever come to the UK. I mean, like, certain people know about it, they don't actually speak about it. So in designing your own curriculum about FGM in India, that I hope that all of you will also talk about actually like all sorts of culture do this. Unfortunately, cultures around the world are very patriarchal and misogynistic, and we deal with it in different ways. It's not to blame other people, but also to show that stopping this practice is not a Western agenda, number one. So you can show that it's being done in the Western world. And you may find that you want to be more egalitarian in how you teach about FGM, in the sense that you don't want people to be ashamed that this has happened to them. That's really, really important. And you don't want parents to feel like they want to harm their children, because all parents don't have the desire to harm their children. They truly believe that performing FGM or female circumcision or whatever you want to call it enhances their children spiritually. So you have to teach them in a compassionate manner and not blaming them. There's some criticism to making FGM illegal, in the sense that, oh, you might separate families and all this stuff, but that's a separate issue that we can go on and talk about it for days. I wouldn't go on and talk about female genital cosmetic surgery. In the UK, it's not something that we promote, and it's not within the curriculum in the OB-GYN training, and obviously like not for someone under the age of 18 as well. There is a debate surrounding like patient autonomy. Obviously, someone who's 18 and they are well aware about the risk. I mean, all surgical procedures is not without its risk, and they still want to go ahead with that procedure. That's a separate story as well. Obviously, there's a separate conversation about the aesthetics of the vulva, like what is deemed to be ideal. So whether there's actually societal pressure for women to get certain procedures, that's a separate story as well. So it's actually quite a complex area. But at the same time, we do want to respect people's autonomy. The current FGM law in the UK doesn't have any age limit. So technically, is female genital cosmetic surgery a form of FGM? There's some guidance from the RCOG, and there are some extra, I think, modules for surgeons who perform cosmetic surgery to undergo before they can actually perform this. And most of the time, people who are asking for aesthetic surgeries on the vulva, a good GP or a good doctor would actually like try to understand the psychology behind it. And when it comes to actually rejuvenating or trying to restore function, this is again a complex thing. I do know that FGM patients have been wanting to ask for this procedure under the NHS. We don't offer it under the NHS. So people in France, in Germany, in Switzerland, they do go abroad and have the surgeries done. So at the moment, the Imperial College London is doing a study. So it's done under a study to see if it actually benefits patients so that we can offer them to patients. So it's not quite an easy topic to talk about. There's lots of opinions and don't really want to go through into this in much detail. But I hope you find this interesting. It's an interesting area.
It is.
With that very, very detailed and interesting discussion by all our panelists, I think we'd like to wrap up and move to the vote of thanks. Julie, if you could give that. I'd like to take this opportunity to remind all the participants that certificates will be issued to only the people who have filled in the post-event form, which has been given in the chat box. So please make it a point to go ahead and do that. And Julie, over to you.
Thank you. I know we have gone beyond time, but I think it's been really, really interesting to listen to all of us coming at it from different perspectives. And the end goal has been to make sure that women's health rights are protected, and we're all working towards that in some ways. So I would like to start by thanking all the panelists for taking the time out. I know it's a busy time of the year, busy day as well. I know I dragged in Hannah and Diana early in the morning from I don't know whether they're doing surgery or not, but I just asked them and they've agreed. So I don't know how much of rescheduling y'all have all done to be a part of this conversation.
That's okay. It's been a pleasure.
So thank you so much. Thank you to SIMSOG for having really been at it in some ways to say that we must have this conversation. And I'm so glad that you chose to do that. You really did follow up with us and say that we want to have this conversation. So a big, big congratulations to you. It's not an easy topic, as all of us have said, and there is a lot more that we could do from here. I'd also like to thank all the participants. I know some of them have dropped off, but I think in some way I hope we have been able to reach their hearts and minds, and they will be more interested in taking this conversation ahead. So a big thank you. We have the resources. I think Shivani and Sana will be compiling the resources. There are a lot of things that are already available. So please feel free to reach out to SIMSOG, to any of us, and we're always there to help, because this we are very clear of that we can't do it on our own. We all have to join hands, and that's the only way that we can make sure that the practice of FGM ends. So thank you very much, Shivani, Sana. Thank you for being the backbone of this conversation so far. Thank you.
Thank you, Julie, for taking out the time, for helping us, and over many months of conversation, making this happen. Thank you to all our speakers from SIMSOG. And thank you to Sana. She has been truly the pillar of this entire panel. She's everything's been smooth sailing thanks to her. I think we can take one quick group photo and then we can call it a night. We request all participants, if possible, to switch on your cameras. All the enthusiastic members from SIMSOG, we extend our thanks for constantly being there, hyping us up and taking part this enthusiastically. You all know who you are. So really, one quick photo and three. Sana, let us know when it's being taken.
Yeah, 1, 2, 3. Okay, one more. Oh, great. Okay, we're done.
Perfect. With that, I think we can call it a night. Thank you so much once again for your valuable time. And we hope you've taken a lot of information and had the fire of advocacy sparked within you. Good night.
Thank you.